Hello to everybody. Now I will be happy to present another interesting paper concerning the nitrosogenesis and oncopharmacogenesis of cutaneous melanoma, where Valentina Broștiu is a co-author of me, and there is a case of neighboring melanomas and dysplastic nevus developing after probable nitroso-candesartan intake. There are no conflict of interest, no financial support. We want to present a 67-year-old female patient who presented to our clinic oncoderma with a mole above the left wrist, which has been changed in shape and color over the past 2 to 3 years. However, this is the history of this lesion is about of no more than 10 years, and the change in these lesions has started in the last 3 years. However, in parallel with this, the patient have for 3 years he has been diagnosed with arterial hypertension and treated during this period with Candesartan 16 milligrams. So during the ambulatory examination, we have found several lesions. Both of them were suspected for cutaneous melanoma or dysplastic nevi. Here you see both of the lesions, the clinical and dermatoscopic appearance and findings, of course, of one and the second lesion were suspected for field melanoma and dysplastic nevi. And the patient has taken several days to take decision where to do this operation, and has taken the decision to remove this mole in another city near Sofia in Plovdiv, from a surgeon, where the surgeon has performed this with a surgical security field of 2 centimeters against all rules for treatment of cutaneous melanoma. However, the first histopathological evaluation of these lesions was that these lesions were melanoma and satellite metastasis, so that it was planned that the patient underwent probable dissection of lymph node and additional targeted therapy by BRAF positivity. But I have taken the decision to perform another histopathological evaluation and send the histopathological slides to our histopathologist, Professor Broștiu, where the evaluation has been done accordingly, and she has evaluated that the first lesion was melanoma in situ, where it could be seen. Here are the melanocytic complexes with disrupted architecture, with clear indications for melanoma. Here on the left you can see these complexes and these nests which have a very irregular architecture. The second lesion was, of course, a superficial spreading melanoma, Clark2 Breslow 0.28, and as already mentioned, these are thin melanomas or melanoma in situ, and a complete excision with 1 centimeter is okay, and the lesions were treated accordingly with 2 centimeters. This is of course, a little bit more as suggested by the American Joint Committee of Cancer rules. However, it is not completely wrong. Here, Professor Broștiu has sent me some images additionally, where the melanoma cells could be identified, and these melanoma nests are, of course, indicative that this is a primary lesion. Once again, on the left, you can see this nice image, the violet melanoma cells, and the postoperative performed the computed tomography on the whole body with contrast, showed no evidence in the presence of metastasis, so the patient was stage 1A, and Candesartan was discontinued, and she was referred to the follow-up in the regional cancer dispensary at her place in residency in Plovdiv region. However, during the postoperative follow-up, several weeks later, we have seen the patient find a new pigmented lesion in the area of the back, skin below the left scapula, corresponding clinically and dermoscopically to a dysplastic nevus, and surgical removal of this lesion was, of course, recommended. The patient does not appear in the following or subsequent weeks. Why we want to present this case? It's a very interesting case. melanoma and nitrosamine intake, melanoma after medication with potentially nitrosamine contaminated drugs. Is this a thesis, a hypothesis? We do not know it, however, we have to check it and we have to follow the international opinion and our own experience during the last years. Of course, we know that the sartans as monomedication or in combination with other potentially or really with nitrosamines or NDSRIs contaminated drugs might contribute to melanoma development and progression, and that nitrosogenesis and oncopharmacogenesis of melanoma seems to be a reality and not a myth. In 2019 and 2023, we know already that the FDA lists for drugs affected by nitrosamines affect more or about 300 preparations and cover all sartans as well as a number of other types of drugs. And we share our own opinion first, that our view or thesis or hypothesis that taking sartans as mono but also as polymedication within the context of polycontamination with nitrosamines or drugs that have been listed in the FDA contamination list might be seen as risky in terms of melanoma development and progression. Monitoring of this intake leads to the conclusion that melanomas could occur after relative short-term contact with nitrosamines taken via drugs listed in this list. Of course, these are two lists. You can follow them on the following pages on the FDA. I have already spoken about this. And you see that all sartans, when we start here with valsartan, losartan, irbesartan, acylsartan, olmesartan, eprosartan, candesartan, and telmisartan, all of them could be contaminated with carcinogens. These carcinogens are NDMA, NDAA, and NMDA. However, you see that there are different carcinogenic potency of all of them, and especially in candesartan, it could be the acceptable daily intake doses could move from 26.5 to 96 nanogram per day. That means this is a very strong carcinogen which could probably trigger some processes concerning carcinogenesis. Very interesting is that we have published also the first case of valsartan-induced melanoma, first description in the medical literature. We have followed also the drug-induced melanoma and possibly the irbesartan-induced melanoma, first description in the world literature. It was 5 years ago. And then we have the irbesartan-induced melanoma, the second case in the world literature. Then we have looked for additional cases and find 4 cases of valsartan and irbesartan-induced cutaneous melanomas and other types of melanomas within the intake of this medication, but not thematized in the discussion section. Then we have started to follow all sartans in our clinic and find that after the intake of olmesartan and valsartan, giant achromatic cutaneous melanoma could occur. Then telmisartan intake together with hydrochlorothiazide. Later you know that hydrochlorothiazide is also listed in the FDA list from 2023 as a potentially contaminated drugs. But when we have this combined intake, we have also find this cutaneous melanoma development and progression. We have also find only that monotherapy with telmisartan could be associated with the development of occult melanoma. Then we have probably more than 100 cases, separate cases, which we have followed. There are multiple primary cutaneous melanomas after medication only with valsartan. Then we have also, when we have followed another collective of patients, it was several years ago, after the intake of valsartan and hydrochlorothiazide, we have find that there is also a possibility of cutaneous melanoma development together or simultaneously with colon carcinoma and Kaposi sarcoma, or choroidal melanoma only with colon carcinoma. This is also a nice possibility. Of course, not nice for the patients, but nice for the science and for evaluating these connections. And then we have find also a valsartan-induced Nevus-associated cutaneous melanoma, then multiple Nevi development after amlodipine and valsartan. Amlodipine is also in the FDA list. And have posted a lot of questions if it is really a pathogenetic relationship or pure coincidence. After that, one of our papers was focused on the development of multiple dysplastic nevi, Meanwhile, I think 4 or 5, together with lentigo maligno on the face, after the combined intake of irbesartan, olmesartan, valsartan with thiazides. Both classes of medications have been listed as potentially contaminated. Nitrosogenesis seems to be an important task. The intake of other, but also declared in the FDA list as potentially contaminated drugs, also appears to be associated with the generation of melanomas. And our thought then to that time was that it is unlikely that the intake of fundamentally different drugs in terms of mechanism of action will lead to the development of the same type of tumor, such as melanoma, for example. The unifying link in these cases could be a single substance that is carcinogenic and should be present in any drug group after whose intake melanoma has arisen. Such common to every drug group substance appears to be that one from nitrosamines or the so-called NDSRIs. So that we have finds also then we have simultaneously development of melanoma and BCC after bisoprolol and furosemide, which has been also listed. We have find the first case of sertraline-induced cutaneous melanoma and published it. Sertraline is also in the FDA list since 2023. And then perindopril, we know that fast OAC inhibitors are as potential contaminated drugs already listed in this list. Then we have found something also very, very interesting, that when we have the combined intake of together of bisoprolol, amlodipine and valsartan HCP, that means 4 or 5 drugs which has been declared as potentially contaminated. This could correspond with the with the clinical picture, with the heaviness of the clinical picture, so that we have not only one melanoma, so that we have primary cutaneous thick melanoma of the breast and thin melanoma and dysplastic mole of the back. Then we have thought that it is very, very important to compare our findings with some international studies, like the external opinion of important US research groups and scientific groups which are following the adverse drug events, especially of these medications. Some of these papers have presented and thematized the role of nitrosamine contamination in the presented data, but others are discussing the topic without specifying if this medication has been contaminated with nitrosamines and not, or not. Why we do all this? This is the main question. Why we follow all these patients with medication intake and the subsequent melanoma development? It is important to share all the also some other papers, like the estimated cancer risk associated with nitrosamine contamination in commonly used medications. Here, another colleague has used also a drug, valsartan, this time not Candesartan, as a case study to estimate the additional cancer risk associated with the intake of NDMA and NDA contamination based on these levels reported by the FDA. And the cancer potencies developed by California's Proposition 65 program and the US Environmental Protection Agency, and they have created specific exposure scenario in order to calculate this risk. And this final conclusion suggests that this contamination of these nitrosamines in drugs are used long-term can increase cancer risk and pose a serious concern to public health. So that when they take, accordingly, the results of the increased amounts of NDMA in valsartan indicate the risk of developing cancer increases to be from between 40 to 126 additional cases per 100,000 population, and for NDA 12 to 48, and this is a disaster. Of course, some papers international have thematized that the real substance had also the possibility to trigger the aggressive behavior of tumor cells, but when already tumor cells are available. And one very interesting paper from Schmidt and colleagues thematizing the intake of sartans and the subsequent development of skin cancer, especially melanoma. And this paper posted that the IRB's long-term intake at low concentrations appears the risk of melanoma development about 53%. But IRB's long-term intake at high concentrations and dose risk of melanoma is about 44 cases. That means when you have the double doses, probably this is a problem. But these are very indicative data where we have to spend some time to think about this, because the risk of developing malignant melanoma is not here affected by the dose of the active substance, because we see that when we have a high concentration, we have a similar risk. So that means that the active substance intake is probably not responsible for the melanoma development. But of course, this is indirect. This is an indicator, and probable factor for this melanoma seems to be a different one, like the nitrosamines, for example. But we have no data in the study whether the active substance used contains nitrosamines. But obviously, yes. Another very interesting paper is from Beatrice Nardon's collective, published in 2017 in Drug Safety, about melanoma and non-melanoma skin cancer associated with angiotensin-converting enzyme inhibitors as angiotensin receptor blockers and thiazides. And here you see that the monotherapy with IRBs bears the risk of developing melanoma between 24 and 225% monotherapy. And this is already indicative. Another very important poster from the same collective has been presented at the American Academy of Dermatology as a poster at Washington, D.C., 2016. And it was a retrospective study on the possible role of sartans in relation to melanoma, and they found 221% risk, more than twofold increase risk for melanoma development only after IRB's monotherapy. Let me know how to explain this. Then we have another paper 8. This is the recently very fresh paper from a French serious collective. They compare the N-nitroso and nitrosodimethylamine contaminated valsartan and risk of cancer development. It was a national cohort study of 1.4 million valsartan users, where they have been divided, have 700,000 contaminated, non-contaminated, and have performed different scenarios to evaluate the risk of development several types of or different types of cancer. However, they have found even not so strong, but a relationship, especially that exposed patients to N-nitrosodimethylamine have a higher risk of liver cancer, about 12%, and melanoma, about 10%. What seems to be important is that nitrosamine-contaminated valsartan melanoma risk, as mentioned, is 10%, but only NDMA-contaminated valsartan was tested regarding this study. However, there is no data about association between the general screening for nitrosamines or different types of nitrosamines and cancer or melanoma development. In order to perform a statement that only NDMA contaminated valsartan has been associated with this risk, you have surely evaluate the other nitrosamines. And such additional testing could imply a probably significant rise in the percentage of the melanomas affected after intent of valsartan, but contaminated with other or all type of nitrosamines. When we have a lower percent, or negative percent, this should be stated in this paper. However, it is not stated. From here, we could only suppose that this percentage is much higher than 10%. Another very new paper for January 2024. Here you see that this is extremely important paper because it is thematizing for the first time, but in the last 20 or 30 years, that nitrosamines or some nitrosamines like the nitrosomorpholin could be powerful photocarcinogens and photomutagens, and when some of them are available in drugs, how we could explain this to the patients. This study has investigated this nitrosamine genotoxicity following UVA radiation without metabolic activation, and after this irradiation, the photo-treated molar was directly mutagenic without the metabolic activation. so that it has been stated that photoactivated nitrosamine attached air pollutants could float in the air and fall into human body, leading to, of course, directly to genotoxicity induced by the irradiated more and cause cancer. However, we can imagine what could come when we take this or similar nitrosamines within the drugs, and this is accumulating to the skin, and these nitrosamines are also photocarcinogenic. This have to be cleared in the coming years. Another paper from the last year, from cultivation to cancer, it is a retrospective review from all some important data about the nitrosamines and other carcinogens in smokeless tobacco and their mutagenic implications. Till now, even there are a lot of data which are speaking about the mutagenicity of nitrosamines in humans. There is also the statement which has to be met that these are not human carcinogens, these are carcinogens in rodents or somewhere else. But we know that tobacco use is one of the major causes of cancer and for morbidity and mortality globally. And we know that some tobacco products like tobacco-specific nitrosamines could be a potent carcinogens and cause mutations in a human DNA, and especially these tobacco-specific nitrosamines are leading to mutations in critical target genes like RAS oncogenes and DP53, and at the same time we know there is an overlapping with these genes which are activated and target of the photocarcinogenesis, so that we have an overlapping between some tobacco-specific nitrosamines with the genes which are affected by in the framework of the photocarcinogenesis, and we have to clarify and position the role of the nitrosamines. Are they strong independent photocarcinogen, or are they only a cofactor for these processes? We have then followed several melanoma which we have a lot of melanomas in dysplastic nevi, and looked especially for medication which has been listed in the FDA list as potential contaminated drugs, and we have found a lot of associations. For example, melanoma dysplastic nevi after ranitidine, riumenidine, moxonidine, lercanidipine, rosuvastatin, and verapamil tranulapril. We have evaluated these drugs because some of them are already listed as carcinogenic potency contaminants with nitrosamines in the FDA list, but some of them are only described as nitroso possibility availability, so that they will probably in near future also be involved in the updated FDA list, and there is a warning sign from our team to the health yes. So that we know that nitrosamines at that time they have not to be presented in these products. This is not in the medicinal products. However, these provisional limits which has been sent to the manufacturers are with the purpose to undertake a voluntary recall if analysis confirm the presence of these impurities in the sartans, but impurities below the established limits will be tolerated for a short period of time just to avoid a shortage of these pharmaceuticals. However, we have now more than 300 medical products, and we do not see the end of this limitation. We have only limitation of the nitrosamine limits in the drugs, which could be sold, and this is of course a real problem in front of the clinicians, patients, and regulatory bodies. The amount of data linking the use of sartan as monomedication is in the case presented, and the development of multiple cutaneous melanomas and dysplastic nevi is a worrying one, because there is not only a single information or observation from our team, there are enough data in the world literature indicative for this relationship. given the additional disclosure of this or some pharmaceutical companies and the FDA about the existing elevated concentrations of these carcinogens like nitrosamines in fast all classes of antihypertensive drugs, and the establishment of causal relationship between the intake of this carcinogen and the development of cutaneous melanoma seems to be a realistic one, so that the extent to which Candesartan in our case use could lead to the occurrence of melanoma in situ, thin melanoma or dysplastic nevi, especially when shared data points in this direction, remains very possible and logically based. Drug-related nitrosogenesis and oncopharmacogenesis are completely new terms in medical science and are very important for the elucidation of skin cancer's pathogenesis. And we know that especially drug-related nitrosogenesis and oncopharmacogenesis remain till now an unresolved dilemma. But what is more important, these two terms are no more a hidden truth. We have published this nice paper in the Georgian Medical News, and we are very proud of it. Thank you for taking the time to listen to the presentation. Wishing all the best from Sofia, Bulgaria. Ciao.